Good morning, good afternoon, good evening, any part of the world or West Africa where you're listening to me. It's really a great pleasure to be part of this initiative by SmileTrain and the West African College of Surgeons. And today I will be delving a bit from the theater to other things that are equally important apart from the core surgery itself. So the topic today is beyond cleft surgery, coping with the challenges of COVID-19 pandemic. I have been introduced. I am a pediatric surgeon at the Lagos University Teaching Hospital. So this is my outline. I will just look a little bit about what the SmileTrain initiative has been doing in the West African sub-region, using Lagos University Teaching Hospital as an example. Then we'll look at some statistics from Africa on COVID-19. And then we'll look at the impact of the pandemic on several aspects of COVID. And then we will probably have a shot at what the new normal is or when we can return to the old normal. And then questions and answers. My disclosures are this: there is no conflict of interest in this presentation. I have not been funded to present here. However, I must say that I'm a member of the National Institute of Health Research, Global Surgery Unit of the University of Birmingham. We have been in collaboration for close to 5 years, and we are worked together within the Global Surge and then recently the COVID Surge Collaboratives. And I will be quoting copiously from some of the work we have done together in that collaborative. So I'm sure that this has been discussed severally in different presentations that have been done in this online series. But I think it's important that we start from exactly the beginning. What is the burden of orofacial clefts? We know that it's been quoted that it could be as high as 1 in 700 in Asian countries. But in the US, the statistics suggest that it's about 1 in 1,600. And in Ghana, there is a work by Peter Agbenoko that suggests that it could be as high as 1 in 763. Although these are hospital records, are not community-based study, the one in Ghana particularly. Even the one in Nigeria is also based on hospital records from SmileTrain partners, and that suggests that it could be 0.5 per 1,000 or 1 in 2,000. I noticed that the SmileTrain actually estimates that every 3 minutes, a child with orofacial cleft is born around the world. That comes to close to 500 babies every day. So it's a relatively huge burden. There are certainly things that are heavier, but in the area of orofacial cleft, it's not something that we can overlook at all. Now, what is the impact of SmileTrain? So I should say that when I was training in the early 2000s, we used to operate on clefts, including the TSS7 types, the lateral cleft. But they come one and far in between. Maybe you do 5 a year or 6 a year. And it's not because there is nothing, it's not because there are no people, but there are several challenges. And then I remember that in 2007, if I'm not mistaken, at IIT in Ibadan, there was the first meeting of trying to bring orofacial cleft surgeons together, including plastic surgeons, orthopedic surgeons, ENT surgeons, pediatric surgeons as well. And with that, the impact of SmileTrain began about 13 years ago in my own little experience. And if I will summarize what SmileTrain has achieved in just over a decade with one word, I will say, is massive. It's just it's difficult to quantify in words. And I've chosen to use the Lagos University where I now work as an example. So in terms of surgical volume, what happened was with the advent of Smile Train, within a year, there was 1,000% increase within a year of Smile Train. So we were operating less than 10, and within a year, we were able to do over 100 in 1 year. This was gotten from Professor Ogunlewe's inaugural lecture when she shared her experience. Secondly, Smile Train has been involved in patient advocacy and education. I would like to share a story here. I was coming from a remote village in Ogun State one day, and I saw a young lady in her 20s or 30s with a cleft lip. I was driving my car, and I just said, "Young lady, oh, how are you? Why are you like this?" And she said, "Well, they couldn't do anything." I said, "Okay, let me see you with your husband." And I saw the two of them, and I just gave them a note to come to Luth, and they didn't pay a dime. And within 3 weeks, after running some investigations, etc., she came. I saw a lady just coming to meet me while driving along that path again, and I could not recognize her. So the Smile Train has been involved in a lot of advocacy. They do a lot of visits to the market. We had much of that yesterday. And then, of course, funding of patient surgery, which is one huge barrier to uptake of surgery. So we have the expertise, but people cannot afford it. But Smile Train came and was able to allow people to have this surgery at no cost. And that has increased not only the number, not only the capacity, because when surgeons are able to do more, they are better at it, their competence improves, but also more patients are now coming at younger age because they now know it could be done. Another thing that Smile Train has done is in training. I'm aware that colleagues were trained and were sent for conference to share their experience. And of course, I saw again the new partnership with the West African College of Surgeons to train 6 surgeons a year over the next 5 years, translating to 30 orofacial cleft surgeons within the next 5 years across the West African region. And I think this is absolutely commendable. It's not something that should be overlooked. Another thing that I think is very, very important with respect to the Smile Train interaction with surgeons in the West African sub-region is that it has produced a pioneer model of working partnership between the high-income countries and low and middle-income countries with such tremendous high-impact outcomes. So it's not just surgical outreaches, but they have become partners on the ground, working with surgeons and equipping them. And even now, I heard from the grapevine that they are even equipping theaters. And this is just massive. I don't know, but on behalf of surgeons from West Africa, I don't know if that's part of my presentation, but I want to say a big thank you to Smile Train and for the great work they've been doing so far. So let's talk about COVID-19 and let's look at some timelines. The severe acute respiratory syndrome coronavirus type 2, the SARS-CoV-2, was originally described in Wuhan, Hubei province in China in December 2019. A month later, the World Health Organization declared it as an epidemic of public health emergency of international concern. A public health emergency of international concern within a month. 2 months later, or actually 6 weeks after that, it had become a pandemic because of the explosive spread to several countries around the world within so short a period of time. No thanks to international air travel that makes mobility across the world so possible within so short a period of time. And the world has become a global village. The first reported case in Africa took about 2 months before it was reported in Egypt in February 2020. And in Nigeria, it was February 27th that we had our index case. What is the current status? This was at last week. The figures change every day, as we know. As at last week, the Christmas Eve, we had 77 million. As of this morning, is now 79 million. And that included about 1.7 million deaths. Egypt, that had only a case in February this year, now, as at Christmas Eve, had close to 130,000 cases with over 7,000 deaths. My dear country, Nigeria, reported our first case February 27. As at Christmas Eve, it was 79,000. Now we are almost 90,000 and over 1,000 deaths. Ghana reported their, as at Christmas Eve, had 53,000 cases with 333 deaths. So you can see that over a short period of time, the virus had become a public health emergency and has a high mortality rate. We are very lucky in Africa that it's not that as predicted. And there have been many, many theories for this, which is not the subject of our discussion today. So if we look at the cases per million population, you will see, I don't know if you can see my cursor, you will see places like Argentina here, places like France and Spain, having 1,000 per population, per million population. And if you look at sub-Saharan Africa, including West Africa, you will see that we are lucky to have less than 100 per million population. Okay. So what is the risk that a patient with orofacial cleft may have COVID-19? The truth is, I don't know. And I'm not sure the scientific community knows either. But if we assume that in West Africa, the burden is 1 in 1,000 orofacial cleft, all right? And we have 100 cases per million in West Africa, then the probability may be 1 in 10. And given that children who constitute the major population with orofacial cleft, except those few adult cases that are now becoming more and more less prominent in the statistics because of the good work of Smile Train, we see that children, the prevalence is about 1.6 to 2.1. And so we can say that probably the likelihood that you are going to see a patient in your clinic presenting with COVID-19 with a cleft may be as low as 0.1 to 0.2%. We will say that is very low. But having said that, eternal vigilance is the price for protection and prevention of healthcare workers. And why did I say this? We know that Africa, West Africa, as well as Sub-Saharan Africa, like other low and middle income countries, have not met the recommended surgeon, anesthetist, and obstetrics ratio of 20 per 100,000 as is recommended. So Many African countries are less than one. If you look at the national surgery, obstetrics, anesthetics, and nursing plans of several countries in West Africa, you'll see that we don't even have up to one of that when the expected ratio is supposed to be up to 20. And therefore, we cannot afford to lose the few healthcare personnel, either doctors or nurses or anesthetists or anyone for that matter. Now, the other question we would ask ourselves is, if the risk, if the mortality is that high, the risk of infectivity is high, should all patients requiring cleft surgery be tested? Again, I'm not sure I have the right answer to that. But for West Africa, at least I can say that we don't have the resources to do that. Even as yet, our testing capacity is far, far below that which is expected. And this is because of resources. We don't have resources. Furthermore, the prevalence, as we have seen, is quite low in children. So it's not likely to be that beneficial if we begin to test every child that comes for cleft surgery. I know some private hospitals and some mission hospitals have attempted to do this, but like I said, it's unlikely to be sustainable. It would be nice to see what others do in their different countries, whether they test people routinely before surgery. But I would like to draw our attention to a recent study published in the British Journal of Surgery, which showed that when when tests are done for major surgeries in high-risk areas, it could be of help. It could help with decision-making as to whether to go on with surgery or not. However, for minor surgeries in low-risk settings, it's been estimated that you need to test 48 times to prevent a single case of respiratory complication. And I'm not sure how cost-effective that will be. Having said that, I think moving forward, for those of us in cleft surgery, we need to continue to apply our university basic precautions with appropriate use of personal protective equipment. And we must assume, as the maxim usually is, that all patients may have. You must assume that every patient you see may or might have COVID-19, and therefore prevent yourself as well as your team, including anesthetic and nursing and support staff, by all means. A recent work published in the British Medical Journal showed that when personal protective equipment are used appropriately, it's been found to be very effective in protecting health workers. And this was done in China, and they looked at about 400 or 600 health workers, and over a couple of months, and not a single one was able to add COVID-19. And one of the things they did was that usually when you are donning and doffing, it's a pair. So somebody else is looking at you and assessing exactly how you are doing it to ensure that you adhere to the protocol. The other question we may need to ask is, how can we prevent patients and health workers during surgery? So it's, as we have said, it's extremely very important to protect our health workers because they are few. For pediatric surgery, for example, I know that even in Nigeria, we are about 1 to 1 million. And I know countries where in Africa, where they have only 1 or 2 pediatric surgeons. So we cannot afford to lose these people at all because of the collateral damage. Now, several guidelines have been given, but I have looked at this specific one that came from us in Africa, and some of us worked together and Lifebox, and we came out with these nuggets. The reference is there and we can look at it. But essentially, at that time, and this was published, I think, around July this year, it was important for people to to develop a clear plan for essential operations. All right, so some operations had to be deferred or delayed, while some had to go on. For example, life-saving emergencies and cancer surgeries and severe congenital malformation had to go on even during the pandemic. We felt that limiting the exposure of healthcare staff and preventing hospital transmission was very, very important. Because of limited resources in many African countries, it was important to conserve PPEs and consumables. And then it was also very, very important to expand critical care and sometimes to repurpose staff. So other staff that may be redundant because they are not operating can then be repurposed to join critical care units to help out. And of course, another very important thing which many people overlooked and which we felt was very, very critical was the psychological wellness of colleagues during this time, because it's very, very difficult for colleagues to lose very close colleagues or even patients they're caring for. And sometimes these may cross ethical considerations, and it was important that there was a provision for that. And I think the second important thing that collaborative did, and I give a lot of credit to Thomas Weiser and his colleagues from Livebox, was the development of COVID-19 checklist, and which we suggested must be used with the WHO surgical safety checklist. And we believe that adherence to these will save a lot of lives by preventing transmission from patients to health workers and even across the hospital. So these were some of the things, these are the direct recommendations, and we can, I apologize that it's a bit busy, but we can look for the paper and read it. And then this is the checklist, which is very similar to the WHO checklist, but a lot of things to the nurses team. You know, you want to know whether the COVID team has been notified. The nursing team should do that. They should place notification tags on the door. The anesthetists need to know that the intubation equipment is assembled and ready, and then what they need to do at pre-intubation. And then the surgeon needs to minimize duration of surgery wherever possible, minimize aerosolization, and only those that are needed should be in the theater. So this is not a time for medical students to be roaming around, etc. And at the end of the operation, how to remove the PPE, where to remove it, and how to dispose it were also documented. Then what is the impact of COVID on cleft surgery? I'm not sure of the specifics with respect to cleft surgery, but I can extrapolate from other surgeries what the impact has been. From a modeling work that we did in the COVID Surge Collaborative, we estimated that there must have been 28.4 million elective surgeries that were canceled over a 12-week period due to lockdowns across the world. Again, the reference is there, and you can even look for your country-specific impact of the lockdowns. From the estimates for West African sub-region, we estimated about 13,000 surgeries canceled every week during the lockdown. And Nigeria being a highly populous country, we had our fair share of about 9,500 from that 13,700. So it is massive. And these are weekly figures. So if we multiply that by 12, then over a 3-month period, you will know what the cost of cancellation is. Definitely, cleft surgeries is not considered an emergency surgery. So these would have been affected by these cancellations. That said, there was another work that was done looking at the collateral damage to children. While delay in elective surgery is inevitable, as we have seen, these workers fear that it resulted in collateral damage among children, because children have a low risk of this infection, but won't have their surgery performed nonetheless because of the effects of the lockdown. So that is an additional pain that children would go through who would have had their surgery done. So what would be the proposal for cleft surgery during the lockdown? Surgeries should continue, but we should use what is known as COVID-19 pathways, COVID-19 free pathways. And what do we mean by that? That is, from the time the patient gets to hospital, to the clinic, to run investigations, to theater, to PACU, and to the wards, there should be a pathway that allows a patient who is not COVID-19 positive to pass through all those places without mixing with COVID-19 positive patients. So patients that are COVID-19 positive should have their own pathways and they should not mix. That way, surgeries could continue for those who are COVID-19 negative, including children with cleft, without any danger of acquiring the disease while in hospital. As I begin to wind down gradually, it's important for us to know what the risk of morbidity or mortality from surgery is in COVID-19 positive patients. We don't have so much data with children, but adult data suggests that operating on COVID-19 positive patients resulted in 1 in 4 deaths. And that's high. And that is irrespective of the surgery, including surgeries as basic as hernias. And then half of them will have pulmonary complications. This data was from about 1,100 patients within the first 3 months of pandemic when surgery continued. The mortality was worse with advancing age, as there was nobody less than 30 years in that series that died. The highest mortality were in those who are above 70 years. So what will I suggest? For mortality and morbidity is likely to be low in children, but if it can be delayed for those that are positive. So we are talking here for a child that comes with cleft lip or cleft palate and is COVID-19 positive, it is better that we delay it and not operate immediately. The next question you would like to ask is, how long should we then wait if we are not going to operate immediately? The early experience suggests that a 4-week delay was very, very helpful. This was in cancer patients that had surgeries during the COVID-19. And you will see that when operation was done within 1 to 2 weeks of their SARS-CoV-2 positive swab results, the mortality was 18%. The mortality was 7%, and pulmonary complication was 18%, compared to 0 when that surgery was done after 4 weeks. So it seems if we waited for about a month for that child, the virus would have cleared and outcomes will be close to that we would expect for COVID negative patients. So what will change with the vaccine? And I think this should be my second to the last slide. I think a lot is likely to change with the vaccine. I think there seems to be positive reports about the vaccine. And if that is sustained, some have suggested that life may become normal again by mid next year, in about 6 months. But the issue is the vaccination had started this month, over 3 or 4 weeks, and there is no nation in Africa or West Africa that has gotten vaccination. So while we are waiting, when the rich across the world have finished vaccinating and protecting themselves, what should we do? We must continue with basic public health principles that have worked, that have protected much of sub-Saharan Africa up until now. So we must continue to wear our face masks. We must continue social distancing. We must continue to clean our hands. Hopefully, with vaccination and with herd immunity thereafter, life will return to normal again. I thank you very much for your attention. I will be happy to take questions. And if there are some that I don't know, the moderator will have to answer on my behalf because he introduced himself as my good friend. Thank you very much.
Thank you very much, Professor Adesoji Oludotu. That's beautiful presentation as always, and as was expected. And of course, the joke at the end of it is also a norm for you. So, distinguished ladies and gentlemen, I think we do not, as of now, have any questions still on the Q&A platform, but I'm sure that suggests that my friend has done a very beautiful, very illuminating job. But I'm going to ask, maybe probably start, and I would encourage audience to still put questions on the chat box, on the Q&A box, if you would, we would have one. But while we're expecting that, maybe my friend could address one or two things. Yeah, you talked about the COVID-19 free pathways, you know, and that seems to be, yeah, what is being said, and I think it's, but the practicality of it, I want us to look at how practicable in a situation where patients go to the same laboratory to run tests, and some patients may be asymptomatic and they could still be able to transmit diseases and all of that. Do you think this is quite practicable? And again, still in addition to that, what is your view about having an infectious disease, a dedicated purpose-built infectious disease building in every hospital, especially tertiary hospital, where such patients can just be, you know, directed to, profile to, immediately they are suspected, rather than using the same laboratory with everybody. We have the facility will have everything, including theater, for that purpose. What's your comment on this?
Thank you very much, Professor Akadri. I know your questions are always tough, but that's fine. We will definitely overcome. Now, with respect to COVID-19 pathways, I must say that it's not as difficult as it sounds. Yeah, okay. It's not as difficult as it sounds. In fact, I must tell you that at the Lagos University Teaching Hospital, during the height of the pandemic, we had something similar without knowing about the study that was done. You know, Professor Bode, who is a pediatric surgeon himself, and the CMD, you know, with his team, just decided that, look, we needed to have a pathway for COVID-19 patients. And so by doing that, you protect all other patients from mixing with them. So a whole block of 120 beds was dedicated to treat COVID-19 patients. And we had a theater not too far from that where COVID-19 positive patients were operated, and they had their ICU and PACU very close by. So during that pandemic, patients who were pregnant and were COVID-19 positive were on that ward will be wheeled to the theater, at their CS done, then we'll go to the PACU and then return back to the wards and elapse their time. And that was done successfully for 7, at least I'm aware, for 7 mothers. And of course, for others that had other surgeries and were positive, the same thing was done. So I think it can be pragmatically done, practically done. It's either you isolate the COVID-19 or you isolate the non-COVID-19 patient. And I agree with you with respect to having an isolation center. I think that was exactly what we did in our own case. So that also is a very, very good example. And I think it's something that we should be thinking about as the second wave is creeping in fast on us. I don't know if I've addressed your question.
No, very, very well, sir. Very well. Let me say to the audience again, you are still welcome to put in questions. Okay, meanwhile, Dr. Professor Ademuyiwa, you talked about mortality rate of 25% within the first 3 months of the pandemic, you know, among COVID-19 positive patients. I want to, I think that at that point in time, there is a lot that we did not know about COVID-19. The information about
I cannot hear you. If you can hear me, I cannot hear you.
Some of the medical labs. Can you hear me now?
Broke up, so I did not hear you, Professor Kadi.
Okay, but can you hear me now?
Yes, I can.
Can you hear me now? Okay, fine. All right. So I was saying that you talked about mortality of about 25% in COVID-19 positive patients within the first 3 months in a study among 1,000 people within the first 3 months. I'm saying that at that time, we know.
Again, you are breaking now. Professor Akadri.
That knowledge of the pathomechanisms and the biology was evolving in time, okay? So do you think that now, with months and updated knowledge of the pathomechanism management of these diseases, do you think that mortality could be significantly reduced? Even if, I know that the recommendation is to wait for 4 months, like for 4 weeks, you know, for COVID-19 positive patients, but you also define those who would require urgent emergency attention, you know, and those will still be susceptible, you know. So in terms of the knowledge increase and all of that, do you think this could have significantly reduced this mortality rate, or will the study be necessary to execute this?
Well, so thank you very much, Professor Kadri, again for that question. I think only data and hard evidence can answer that question. The reason I'm saying that is this. We all know that COVID-19 affects one of the most important organs of the body, the lungs. And we know that surgery requires taking over respiration, and it's going to stress the lungs. As you saw, there were half of the patients had pulmonary complications. Even in non-COVID-19 patients, when you have pulmonary complications following surgery, mortality is higher than when you don't. So it's difficult to now say what percentage would have changed, even with our knowledge. And that is why it's being suggested that if surgery must continue, for those that are non-COVID-19 positive, we should try and use COVID-19 free pathways. For those that are COVID-19 positive and do not need emergency, we should wait for 4 weeks. For those that we can't wait, I mean, we just have to do something. So we do something, but we don't have data yet from those that are doing that to be able to know if the statistic has changed. But we will. It's another thing that we should look at. I agree with you absolutely, that with improved knowledge, it's likely that the figures will come down. But how much, we may not be able to say.
Thank you very much. That's another challenge to the global surge and COVID surge, to look at those patients that are still being operated for emergencies and all of that. I will have 2 more things. Okay. Yeah, there's a question here. What do you think of the introduction of COVID-19 screening in preoperative Cleft checkup. I think you talked about that, or maybe you can say one or two things to the person who asked the question. Pre-operative testing.
Yeah. So I'm sure the
Pre-operative.
person probably did not was not around when I was talking about it or something. So what we said is that we don't have the resources. Let's not deceive ourselves to be testing everybody that comes to hospital, because even our capacity for testing now is not as good as it is. Many people, I think in Africa, it's only South Africa and probably Ghana, using their unique testing methods that have really done some good testing per population. We have not. So I don't see it as something that that we will be able to do on a sustainable level. We can start now and say, okay, let's do it, but I'm not sure we can sustain it because of resources. But the more important thing is the science behind it. Is it necessary to do it when early figures suggest that you need to do 48 of those tests to prevent only one pulmonary complication? Would that be something that we can defend with policymakers to pour resources into at that wide range? So because of that, I think, and then for cleft lip, it's not essentially life-saving. It's not an emergency. So they can as well wait. If we have a patient that is positive, they can as well wait for 4 months. If the patient is not positive, I don't think we need to do the screening. Coupled with the fact that the prevalence in children is very, very low, is about 1% compared to that of adults. So again, spending resources on that does not seem to make it an attractive option for now. That would be my submission.
Thank you very much, Professor Ademuyiwa. You said that again very elusively. Now, I would want you to comment on the new strain of COVID-19 has been found in the UK. There's about 23 mutations have been noted, about 40 to 70% increased infectivity, with this new strain. How do you think this would impact our practice? I don't know how much has been said in terms of the clinical symptomatology and all of that, but that has been any documented evidence of any change or any difference. How will this impact even the vaccine that is evolving? I want your comment on this and how this new strain will affect. And also, Nigeria is said to have found a new strain which is so far not found to be the same as the one that has been found in the UK. What is the implication of all of this in our practice?
Thank you very much. The first thing that I think we need to remind ourselves from basic virology principles is that these viruses are prone to mutation. So it's a normal finding. Over time, they try to mutate so that they can survive, because the old one, you may get immunity against it, and the virus wants to continue, so they mutate. And in the process of mutation, there are certain things that may change, like you said, the infectivity, etc. Now, I read a report sometime back where it was said that that particular strain in the UK has actually been found in Nigeria prior to the time it was found in the UK. There is a particular university in Nigeria known for the virology prowess who has said that, but they've not published it, so we may not be able to work with that. But what is the import of this? The import is eternal vigilance. We cannot rest on our oars yet. Even apart from COVID-19, another thing can come up. So the import for us is, therefore, we must continue to employ time
Hello. I'm not hearing you again. I don't know whether it's from my side
or not.
Hello, you are muted. Professor Ademuyiwa, you are
Okay,
muted.
can you hear me again?
Yes, I
Right.
can hear you now.
So because of the cross immunity against this, that could help us. So I am just hoping, you know, with respect to, I'm sorry about that. I'm so sorry about that. I'm so sorry about that. So with respect to that, I believe that probably the cross immunity may help us. I'm not sure. I'm not a immunologist and I'm not a virologist, but hoping that those that are vaccinated, if we are able to achieve the herd immunity, we may then be able to probably fight against these new strains. But I'm not sure.
Thank you very much, Professor. Thank you very much, Professor Ademuyiwa. There are two more things on which I would like your comments before we close this. People are not bringing more questions, and I'm learning a lot from you. Maybe I'm the one monopolizing your knowledge right now. I want to know, with respect to training, some of the recommendations was that medical students, trainees should not do surgeries. Intubation should be done by the expert to minimize time, and all of that. Surgery should be done as quickly as possible. Let the best hand do it and all that. So trainees are deprived of training for almost about a year now, and this is being done in collaboration with West African College of Surgeons. How does this impact on training? How do you advise the college to put this into consideration in the time maybe given for the residents, the tenure of their training, or maybe training institutions, and also for college in terms of overall training, curriculum, and all of that? How do you think this could be a pandemic or similar things should be put into consideration in terms of our training curriculum?
Okay, thank you very much. Before I take that, I saw a question from Peter Mossing, who is asking whether cleft palate surgery should be regarded as a higher priority than cleft lip because of more adverse consequences of delay. Maybe I can take that quickly and then I'll come back to your question.
Yeah.
I agree entirely with Peter on that. I think cleft palate, definitely the consequences of delay are worse with respect to cleft lip. And so, like I told you, even during the heat of the pandemic, certain surgeries were still being performed. So life-saving surgeries, cancer surgeries, and severe congenital anomalies. So definitely, this could be this could be a reason to advocate that cleft palate surgeries could continue in spite of the pandemic at this time. Having said that, if we have a patient who is COVID-19 positive with cleft palate, I would still suggest that we wait for a month because I'm not sure a delay by 1 month that will improve surgical outcome will be too much a cost to pay. Back to your question on training. It's massive, it's unprecedented, the effect of this pandemic. It's not only on training, even on economy, on livelihoods of people, on health systems, on virtually every aspect of our lives. And specifically with training, I would want to think this is a good time, and I think the West African College of Surgeons is already thinking about that, to empower our simulation skills laboratories, to ensure that even though there may not be real life patients, in every accredited training center, there is a lab where residents could go to test their hands, on different surgical techniques and procedures. And that could be assessed. As a matter of fact, some educationalists now are thinking that simulation, it should be, even when the pandemic resolves, should be a permanent part of our curriculum, because they have found out that you are able to assess the competence, all right, by repetition of residents. And by the time they have achieved a level of confidence and they go to meet real life patients, they are far better than people who have not been exposed to simulation at all. So I think that one strong point that this pandemic has made in our training and the curriculum of our residents is that we must embrace simulation and simulation techniques in educational curriculum. And with that, I believe we may be able to bridge the gap that is being created by the non-exposure of residents and trainees to clinical patients.
Thank you very much. That's very brilliant submission there. Okay, finally, you made in the last comment in the last slide there, you talked about return to normal. And I have actually often questioned this issue of returning to normal. My question is, how normal was the normal before COVID? Because I found that some of the things that we have been encouraged to do actually should have been some things that we do routinely, even in the pre-COVID era, but we took them for granted. And now people are learning how to doff and doff PPEs. That should have been part of our training. You know, people are encouraged to wear masks. Even some people, when they are examining patients, you know, and things like that, wash your hand after every patient. They are basic infection control practices, which were not being put into practice. So should we really return to the normal things where we take things that should have been not routine for granted, or we should return to a normal? What's your comment about that?
Okay, thank you very much. That's a very, very good point you have raised. Let me just reply, Mr. Nkyobi, that I have addressed Professor Moss's question already. Thank you very much. Now, when we talk of return to normal, definitely we are not talking with respect to infection prevention control mechanisms alone. We are talking about life being normal. Your ability to go to the beach again, to go to the cinemas, to be able to fly, to hold conferences, which this year seems to just be all virtual. So that's what we mean. With respect to adherence to infection prevention control, absolutely I agree that this has taught us a very, very huge lesson, and we must not return to that old normal with respect to this. In fact, we must continue to do this. And that's why I made the point I made, that the mutation will continue. There could be other strains that will come. So we must adhere to time-honored public health principles, you know, and make sure that we do all that is necessary with respect to that. Thank you very much.
Thank you very much, Professor Ademuyiwa. It's been quite a very illuminating time with you. I'm sure every participant will know that this is worth their time. There are a lot of commendations for you on the platform. Fantastic presentation, tremendous presentation. There's no adjective that has not been used there to describe the fabulous presentation you have brought to us today. Thank you very much. I'm going to hand over to Nicole to make some other announcements, even as she winds up the year, the end of the year presentation. Merry Christmas to all you all. A compliment of the season to you all. Thank you. Nicole?
Thank you very much.
Thank you, Prof. Thank you so much. I will hand over to Professor Bernard Djipourom. Prof, you have the floor, please.
Thank you so much, Nicole. I think mine is want to acknowledge that Professor Ademuyiwa has done justice to the topic, and it's been very lucid. Maybe because we are all surgeons, we need to, let me just add one or two words to what he said. I hope you can hear me.
Yes, Prof, I can hear you. Thank you very much, sir.
Yes, yeah. To say that the time that he's saying, about 6 months that we may be returning to normal, I'm a bit skeptical about that. I think that knowing what we still know, the much that we know about the virus and the vaccines for now are not really preventing you from contracting this disease, not exactly the way we've known TB or yellow fever, measles vaccine. They're going to they currently reduce some aspects of the disease presentation and mortality, but not really preventing. People are still getting it. But we hope there will be improvement. And because it's a pandemic, everything is being grown. So a good number of the vaccines, as you know now, are not really FDA approved. They are emergency use authorization approved. So it's to serve as part of throwing so much at it. And I think maybe 6 months will be too early. But correctly, we should really hope that our setting and all what we're doing and the mutations of the virus and exposures will increase herd immunity. And that will largely lead us to the place. I also want to totally agree that with these children, in elective settings that Cleft operations are, we should give that minimum of 4 weeks. We can even go beyond that. There's hardly any room for making a child come down with COVID because of an elective surgery. And for their small size and nature, we know that if they really come down with the disease, it will be overwhelming, not just to the respiratory system, but to others. So I want to endorse what you're saying, that that minimum should really be 4 weeks. So thank you very much for putting that emphasis. And most of the centers, it's easier to isolate those who have the COVID, as Luth did, and then consciously try to create a pathway for non-COVID patients. That's more difficult. But then clearly, if we give the practitioners an assumption that they are all potentially COVID positive, if we give them PPEs all the time and say people should maintain the protocol, then these kids will likely come out better and least likely to be infected. Again, I think we should reduce the number of surgeries in a day that's being done, because numbers do increase the chances of slips being made. So that's being practiced a lot. And the kids, as Smile Train has always pushed for, should have top priority by being early for operation. So if we continue along this line, we should be able to spare them the chance of their contracting COVID. But I know that some of the questions didn't come as you expected, because we were just admiring your handsome face during this Christmas while listening. So again, since I know you, I'm not surprised that you've done justice to this. So thank you very much. We'll look forward to seeing you again. And very important to add that simulation is part of what WACS is planning. And the college is building a big simulation center in Abuja. Over time, at some stage, we may need bodies to support that venture. I know that when it gets to an aspect that Smile Train will participate, they won't hesitate. But that's part of it, because we want an opportunity to reduce, to improve training, but without exposing patients unnecessarily to danger. So WACS is thinking along that line. We hope that we will actualize it sooner than later. And for me, is to thank Smile Train over and over again for being a worthy partner with WACS in West Africa in training. They have lived up to whatever expectations we had in developing an MOU with them. Thank you, Nicole and your team. Thank you, Kiru, Obi, and your team. Thanks very much. Wonderful Christmas, and see you people in the new year. Thank you.